So it's my pleasure to introduce our first session, Viral Infections and Organ Transplantation, chaired by Dr. Samantha Ng. Dr. Samantha is a consultant nephrologist with Metro South Kidney and Transplant Services and the Queensland Kidney Transplant Service. She has interests in equity and diversity in kidney care and in transplantation. Samantha is the current chair and a founding member of Young Australia-New Zealand Society of Nephrology, is the wellness officer for her unit, and is a founding member of the Metro South Kidney and Transplants Friday Lunch Club. Outside of medicine, Samantha enjoys reading, baking, traveling, and spending time with her beloved greyhound. And please join me in welcoming Dr. Ng and our speakers for the first session.
Thanks, Carpy. I'm not a clinical researcher, so I had to put lunch on my bio. It's a very important part of our unit. Thank you very much for coming. I'd like to introduce our first session, which is Viral Infections and Organ Transplantation. It's been my pleasure to organise the conference again this year with my excellent group of co-organisers. Please welcome Dr. Sophie Wen, our first presenter on RSV prevention in transplant recipients. Dr. Wen's a paediatric infectious diseases physician at QCH and medical lead of the Queensland Specialist Immunisation Service. Her work focuses on infection prevention and optimisation of immunisation strategies in vulnerable populations, including children and immunocompromised. Thank you.
Good morning, everyone. Thank you for the opportunity to talk to you today. So I was asked to talk on RSV prevention in transplant recipients. And before I begin, I also like to pay my respect to the traditional custodians on the lands on which we have the privilege to work on and meet today, the land of the Yagara and Turrbal people in Meanjin, and pay my respects to Aboriginal and Torres Strait Islander elders, past, present, and emerging. I am a paediatrician, but hopefully that I will bring some adult data into this talk as well. So RSV is recognised as an important cause of morbidity and mortality in transplant recipients. Yet until very recently, we didn't have any tools to help prevent this infection. So in this talk today, I'll briefly review the burden of RSV disease in transplant recipients, and before discussing emerging prevention strategies, including monoclonal antibodies and vaccines, and finishing off with some practical considerations for transplant care. So RSV in HSCT recipients, the incidence in the literature varies depending on the season as well as the geographic location. In pediatric HSCT, the incidence of RSV has been reported somewhere between 1 to 17% and a mortality rate of 5% or less. Whereas RSV in adult HSCT, the incidence has been reported somewhere between 1.5 to 12%, but a much higher mortality rate of 20 to 40%. It is thought that the early period after HSCT, there is incomplete humoral immune reconstitution and therefore predisposes these individuals at much higher risk of severe infection. And the higher risk of developing pneumonia following RSV is noted in the pre-engraftment period. And likewise, those that had an allogenic transplant is found to have almost 10 times more likely risk of acquiring a viral upper respiratory infection than autologous, as well as a higher mortality rate. So in terms of risk factors for the progression of RSV from upper to lower respiratory tract infection and the mortality in HSCT, these risk factors have been delineated in adults. And as you can see listed in the table, the various risk factors, RSV diagnosis, and the hazard ratios for progression. And the scores adds up to a low risk of 0 to 2, a moderate risk of 3 to 6, and high risk of 7 to 12. And it's noted that patients with profound lymphopenia and early post-transplant infections are at high risk of progression. Can we apply the same risk factors, or what they call the immunodeficiency scoring index, to children post HSCT or solid organ transplants? And so this study was done in 2023 in US, where they included both HSCT as well as solid organ transplant recipients across 22 US transplant centers who had RSV within the first year of their transplant. And they had in total 352 patients, and of which 2/3 were post HSCT and a third is solid organ. And out of that, 27 cases progressed to a lower respiratory tract infection, with 3 deaths that were related to RSV. But the median ISI score was 1. So the ISI categories did not significantly predict progression to lower respiratory tract infection or RSV-related death in children. And we need to do more work in defining what a scoring system is for children that will allow us to effectively predict in that cohort what the greatest RSV risk is to progression for severe disease and mortality. So now looking at solid organ transplant recipients specifically, there have been few studies that have evaluated the burden of RSV disease in solid organ transplant recipients. This study examined RSV infection in adult heart, lung, liver, and kidney transplant recipients over a 10-year period between 2014 and 2023, using a large multi-center electronic health record from the US. In total, there were over 34,000 transplant recipients who were tested for RSV, with just approximately 1,600 confirmed infections. And over this period of time, the cumulative incidence of RSV pneumonia has increased from 0.9% in 2014 to 4.7% in 2023. However, the risk of RSV pneumonia is not the same across transplant types, with the highest incidence observed in heart and liver transplant recipients, while kidney transplant recipients have substantially lower rates. The same can also be said regarding pediatric cardiac transplants in the risk profile. This is a cohort study from Copenhagen, which looked at influenza and RSV infection in adult solid organ transplant recipients, which included lung and non-lung transplants. And when looking at time to positive tests following transplantation, influenza infections were detected more frequently. However, you can also see that RSV infections also occurred consistently throughout the follow-up period. Importantly, both viruses were associated with a substantial increase in mortality following infection. Influenza infection was associated with roughly a 3-fold increase in mortality, while RSV infection was associated with nearly 5-fold increase in the first 6 months after infection. I just want to briefly touch on RSV and lung transplant recipients. So RSV infection, like all other respiratory viral infections, can cause direct pulmonary damage to the lung transplant, and that can lead to both immediate and long-term effects in the allograft function. And so it can be associated with chronic lung allograft dysfunction. And in the literature, describe a 2 to 3-fold increase for this in adult lung transplant recipients with respiratory viral infections. And acute mortality rate has been reported between 10 to 20%. Now I'm going to switch tack and focus on the virus itself. So the RSV variant consists of 9 structural proteins, of which 5 proteins have been targeted for RSV intervention in clinical trials. And you can see that on the right-hand side of the figure, the target proteins that have been looked at for clinical trials. And the F protein is probably the most well-known. So how does RSV cause problems? RSV particles enter the cell by interacting with host cell receptors that bind to either RSVG or RSVF. And the F protein has a critical role in host cell defense and host cell infection. It has both a pre-fusion and a post-fusion conformation, which offers different challenges for RSV for vaccines and monoclonal antibody design, as they have distinct epitopes that are available for neutralizing antibodies, as you can see on the figure to your right. And so earlier vaccines were unable to provide sufficient protection as they used the post-F conformation for the vaccine antigen. So stabilization of the pre-F conformation has made it possible to develop effective subunit vaccines. This gives you an overview of RSV vaccine candidates by preventative approach. And actually, this needs updating as well, as many of these are now in use. So from the monoclonal antibody perspective, we have nirsevimab, palivizumab, and clesrovimab. And then from a subunit or protein-based vaccine perspective, we have RSV pre-F, and that's the Abrysvo vaccine. And you have the RSV pre-F3, which is the Arexvy vaccine. And then in the mRNA space, there's currently 1 vaccine that is registered for use. So in terms of RSV prevention strategy, there's really 3 main approaches. So maternal vaccination, monoclonal antibodies, and active vaccination. The primary target population for RSV immunization includes infants, young children, and older and high-risk adults. Active immunization is the preferred strategy for the pediatric adult population, whereas for infants, passive immunization either by monoclonal antibodies or maternal immunization during pregnancy is the preferred approach. Despite young children being blamed or claimed to be the major contributor for RSV transmission, the precise role of specific age groups in transmission remains unclear. Also, the potential effect of vaccines targeting young children on RSV transmission and their indirect protective effect on infants in high risk and older adults is not known. This slide summarizes the RSV prevention therapeutics that are currently registered for use in Australia. And as you can see, we have 2 vaccines and 2 monoclonal antibodies available to us. So Brisvo is a protein subunit vaccine, and that's been licensed for use in pregnant people between 28 to 36 weeks gestation, and that is funded on the National Immunisation Program. It's also registered for use in adults over 60 years and over. RSV, on the other hand, is an adjuvanted protein vaccine, and that's been registered for use in adults between 50 to 59 years old with specified medical conditions and those that are 60 years or over. Beyfortus, or nirsevimab, is a monoclonal antibody, and that's registered for use in children from birth to under 2 years of age, and that is funded depending on where you are in Australia. And then finally, we have paediatric, which has been around for a long time and largely prior to nirsevimab has been given as a risk factor-based program, and that we are no longer using for Queensland paediatric program. I thought I'll just quickly run through the Queensland Paediatric RSV program because it gives you an indication of the timeline and then also the impact on the RSV notification and hospitalisation we see in Queensland. And so in November 2023, nirsevimab was approved by the TGA for use. And in Queensland, we announced the nirsevimab prevention program in children in March 2024. And following on from that, you have the Queensland maternal vaccination program with Brisvo in December 2024, and that became available through the National Immunisation Program in February 2025. So what is the impact of the Queensland RSV prevention program? This figure shows the cumulative RSV hospitalisation in infants under 6 months in Queensland. So following the introduction of the Queensland Paediatric RSV Prevention Program in April 2024, you can see that hospitalisation in 2025 under 6 months, so the red line, were markedly lower than in both 2023 and 2024, demonstrating the substantial early impact of the program. Although this program focuses on infants, it highlights how powerful RSV prevention strategies can be in reducing severe disease, and something that is relevant for other high-risk populations such as transplant recipients. In the RSV prevention program, some infants are eligible for a second dose as they enter into their second RSV season. And for kids with significant immunosuppressions, and that includes kids that are solid organ transplant recipients and those that are stem cell transplant recipients, are eligible for a second dose in under 2 years of age. So what's happening in RSV notification in Queensland in 2025? As you can see, the majority of notifications are still in children under 5 years of age. However, there's not an insignificant proportion of notifications in those that are over 65 years of age. And from a hospitalisation perspective, despite the lower number of notifications in the under 6-month age group, they're still much more likely to be admitted for the RSV compared to all other age groups. However, it's important to highlight that the 65 plus age group actually accounts for the second highest percentage in hospitalisation. So looking at nirsevimab in immunocompromised children, really there's not a whole lot of data out there. And I'm really going to focus on 2 studies. And so this is one of the major studies that I could find that looked at nirsevimab in immunocompromised children, focusing on safety and pharmacokinetics. And so they included 100 participants, and of which 16 had previous transplants. And what they found is that nirsevimab serum concentration at day 151, which is what's reported in the registration trials, was similar to those effective in preventing medically attended RSV lower respiratory tract infections in healthy infants. And they also had no protocol-defined medically attended RSV lower respiratory tract infections up to day 151 in this particular cohort. And so in immunocompromised children under 2 years of age, nirsevimab was well tolerated with no safety concerns, and the serum concentrations were supportive of efficacy. This is the only other paper that I could find that looked at nirsevimab in immunocompromised children. This specifically looks at cancer and stem cell transplant recipients from Canada. And so the numbers were relatively small, but what came out of that to me is that of the 42 eligible patients, more than half of them only more than half, 62% received nirsevimab, which highlights that there is a significant delay and missed opportunities for administration in this vulnerable cohort of patients. So now looking at adults, RSV vaccination. So this looked at 92 stem cell transplant recipients that were vaccinated with Abrysvo. They measured vaccine immunogenicity at baseline, as well as 4 and 12 weeks post-vaccination. And you can see here that lower titers at baseline correlated with a shorter interval after transplant, which is figure A, and a lower lymphocyte count, which is figure B, and then the use of immunosuppression within 3 months preceding the vaccination, which is figure C. And what's also important to note is that those that were vaccinated more than a year post their transplant, 75% seroconverted. However, those that were vaccinated within a year of their transplant, only 9% seroconverted. That has significant implications as well. In pediatrics, we start vaccinating 6 months post-transplantation. And there is no serious adverse events noted with the use of Abrysvo in this particular cohort. There are 2 other studies that I want to briefly touch on. So on the left, you've got vaccination with the RSV in lung transplant as well as allo stem cell transplant. In the lung transplant, they reported a seroconversion rate of 48.7%, and the allo stem cell transplant, just a third has seroconverted. And they also noted that longer time post-transplant is associated with higher rates of seroconversion, but the median time was 16 months versus those that seroconverted versus those that 16 month that did not seroconvert versus 30-month post-transplant for those that did, which is quite significantly post-transplant period. And then looking at vaccination with either RSV or Abrysvo in solid organ transplants in adults. So this study had 31 solid organ transplants included. What they found is that they had better neutralization with RSV, and that may be possibly due to the augmentation by the vaccine adjuvant. They had a slightly higher rate of seroconversion in this entire cohort with 60%. And now looking at mRNA vaccination, and so the Imbrevia is registered for use in Australia in adults 60 years or over. It uses the same RSV pre-F antigen and is based on the same NRA vaccine platform that's used for the COVID-19 vaccine. So there's a clinical trials done in 60-year-old or older adults, which showed an 84% efficacy against RSV-associated lower respiratory tract disease with at least 2 signs or symptoms and no safety concerns. There is an interim report on a phase 3 trial of mRNA RSV vaccine in solid organ transplants. So this study so far has 146 adults with liver, kidney, or lung transplant who were given 2 doses of mRNA RSV vaccine 56 days apart. And they found no vaccine-related discontinuation, death, or adverse events of special interest or transplant rejection within 28 days of both doses of the vaccine. Importantly, 1 dose was noted to be immunogenic across all solid organ transplant types. And the added benefit of the second dose was more apparent in kidney and lung transplant recipients and those that are under 2 years post-transplant and those that are on mycophenolate. They were able to demonstrate durable antibody and cellular responses through to day 181. So that's quite promising in the adult space. The same can't be said in the pediatric space. RSV vaccine development has a very checkered history in pediatrics. In the 1960s, a formalin inactivated RSV vaccine was given to young children, and that subsequently led to vaccine enhanced respiratory disease, with those children later encountering much more severe disease with natural infection and death. And so that has led to a significant disruption in RSV vaccine development for many decades. And Moderna was brave. They went ahead with mRNA RSV vaccine in children. And as you can see here in the table, in the 5 to 7 month old infants who are RSV naive and vaccinated with either mRNA RSV vaccine or the combination of RSV HMPV vaccine, there is a significantly higher rate of severe and hospitalized RSV compared to those that were given placebo. So this trial was aborted. And so mRNA RSV vaccination is probably not going to be an option in children in the near future anyway. So what do we do from a clinical perspective? Helpfully, the Infectious Disease Society of America had published in 2025 guidelines on the use of RSV vaccines for the prevention of seasonal RSV infection. And I've just extrapolated from the guideline in terms of the timing of RSV vaccination in the immunocompromised patients. So they recommend for solid organ transplants that you ideally vaccinate them at least 2 weeks pre-solid organ transplant or 6 months post-transplant. However, if you're peak RSV season, you could look at giving it as early as 1 month after transplant. For malignancy and HSCT or CAR-T, really the malignancy one's optimal timing again is 2 weeks or more before starting chemotherapy or greater than 6 months post completion. And likewise for transplant is greater than 6 months post transplantation. And then in solid tumor with chemotherapy, ideally 2 weeks before starting therapy. However, you can vaccinate during or after. So there are many, many unanswered questions in this space. We don't have correlated protection and immunogenicity thresholds specific to transplant recipients. We don't know how long the duration of protection is and how quickly the immunity wanes and what the role of booster doses are in this space. We don't know what the optimal vaccine platform is. Is mRNA better than the subunit vaccines? And what are the dosing strategies for transplant populations? We need real-world vaccine effectiveness data in this particular cohort of patients, as well as expanded safety data. And also looking at strategies to how to enhance vaccine responses, whether the option of temporary modification of immunosuppression is an option, or is adjuvanted vaccine should be the way we go. And there's also interesting early antiviral therapies that could be considered as well. And finally, the role of RSV vaccinations in children and where we're going next with that. So my take-home messages are RSV is an important cause of morbidity and mortality in transplant recipients. There are new prevention tools that are available, including vaccines and long-acting monoclonal antibodies. Early data suggests that RSV vaccines are safe in transplant recipients, but immunogenicity certainly varies with timing and immune status. The optimal timing of vaccination after transplant remains uncertain, and ongoing studies will help us define the role of RSV vaccination in this cohort. Thank you.
Thank you, Dr. Wen. I wrote down heaps of things that I'm going to ask you about in the question session at the end. But please, if you've got questions, take note of them. We'll have a nice opportunity to ask all of our presenters at the conclusion of the presentations.